In the very beginning, I would like to thank you today our valuable speaker, Professor Michael Hutz, to come. And I am Dr. P.Y. Cho. Just like the prior mentions, maybe I'm the founder of the ICC webinar, and this is a regular webinar, probably bi-weekly, a month. And we deliver the knowledge, including the craniofacial surgery, especially in orthodontics, sleep medicine, jaw surgery, and craniofacial surgery as well. So today we are so happy to have Professor Michael Hutz to be here with all of us. Today we have two co-moderators. The first one is Dr. Junior Tu, and the second one is our very good friend Prior. So I would like to introduce the Professor Michael Hutz. Professor Hutz is board certified in both sleep medicine and otolaryngology, head and neck surgery. Dr. Hutz completed his otolaryngologist residency at Loyola University Medical Center and went on to complete a fellowship in sleep medicine and surgery at the University of Pennsylvania. He is the section head of the sleep surgery at Rush University Medical Center in Chicago and specializes in CPAP alternative interventions for patients with OSA. These include drug-induced sleep endoscopy with positive airway pressures, nasal surgery, soft tissue surgery, hypoglossal nerve stimulation, and skeletal surgery, such as surgically assisted rapid palatal expansion and maxillomandibular advancement surgery. He has been involved in a number of clinical trials, primarily in the field of neurostimulations. He is the associate editor for the third edition of the sleep surgery textbook, Sleep Apnea and Snoring, and has lectured both nationally and internationally on a range of sleep surgery topics. He served on the board of directors for the International Surgical Sleep Society and as an editorial board member for the Journal of Clinical Sleep Medicine, and is a reviewer for a number of prominent sleep medicine and otolaryngology journals. Thank you for Professor Michael Hutz to give us such a great lectures. And later I will invite Prior to give us a brief introduction for our three panelists today. Prior, please. Thank you.
Hi everyone, it's an honor to be here again and to see some of you. So I would like to introduce our valuable panelists for the sessions. The first one is Dr. Jelena Roden. She is the assistant professor at Universities of Pennsylvania and is board certified in both otolaryngology and sleep medicine. She completed otolaryngology residency at Thomas Jefferson University Hospital, a hybrid fellowship in sleep medicine and sleep surgery at the Universities of Pennsylvania, and then an additional fellowship at sleep surgery at Stanford University. She's also a co-director of the CPAP Alternative Clinic at the Universities of Pennsylvania and the APD of the Otolaryngology Residency Program at the Universities of Pennsylvania. She specializes in and provides both medical and surgical options for treating sleep apnea. And the second panelist, Dr. Sasikan Phumkonsan. She is the clinical instructor at Gravity Hospital, Thailand, specialized in sleep medicine and surgery. With over 7 years of experience, she managed sleep-related disorder through various interventions, including drug-induced sleep endoscopy and surgical procedure. After completing her residency and fellowship at Stanford University, now she was the leader of Skeletal sleep surgery in Thailand. And the last panelist, Dr. Shi Lee. He's the consultant in oral and maxillofacial surgery at Kutek Quoc Hospital and a visiting consultant at Tan Tock Seng Hospital in Singapore. A graduate of Universities of Melbourne, he specialized in sleep apnea surgery, jaw surgery, dental implant, and facial trauma management. with advanced training at the Chang Memorial Hospital from Taiwan. And now it's time for presentation from Dr. Michael Hutz on the topic of the impact of skeletal surgery for obstructive sleep apnea. Welcome, Dr. Michael Hutz.
Yes, thank you so much for the warm introduction. I'm very excited to be invited, and I'd like to thank Dr. Cho and the whole team at the Craniofacial team at Chang. It's a great honor to be here this morning. Morning for me, nighttime for you, in Chicago here. So, my disclosures are not applicable to this talk. I'm a consultant for a number of different kind of new neurostimulation companies. Skeletal surgery for sleep apnea is a very broad topic. And so, the main things I'm going to cover are maxillomandibular advancement surgery and maxillary expansion and how they kind of factor into treating obstructive sleep apnea. And then I have a number of case presentations we're going to go through at the end. So I know many of you are kind of fully aware of this already, but obstructive sleep apnea involves kind of repetitive collapse of primarily the pharyngeal or upper airway. And that collapse either leads to complete blockages in breathing, known as apneas, or flow-restricted breathing, known as hypopneas. And these intermittent gas disturbances lead to recurrent episodes of arousals or sympathetic activation where the patient is being awoken kind of all night. And, these are episodes that a patient has during sleep where they will be breathing normally. They'll have an apneic episode with complete cessation or blockage of airflow. They'll desaturate. They'll finally have an arousal. The muscle tone of their airway improves. They resaturate, and then they have the same episode, and this occurs over and over and over. Obstructive sleep apnea is the most commonly related breathing disorder during sleep. I think this is probably grossly underestimating how many people actually have sleep apnea, and I think home sleep testing has been able to improve how many people are actually getting appropriately diagnosed. But about a quarter of men, about 16% of women aged 60 to 70 have at least moderate sleep apnea. And as we get older, the risk or odds ratio increases by 2.2-fold for every 10-year increase in risk. We know that there's an independent risk factor with increased mortality and obviously many things with cardiovascular morbidity, such as heart attacks, strokes, atrial fibrillation. There's now links to dementia with untreated sleep apnea. So very important that we treat it. The prevalence of sleep apnea is increasing, and some people wonder whether or not it's more related to why we see more thyroid cancers now. And, that is predominantly because we're doing a better job screening. So we have better imaging modalities to pick up thyroid cancers earlier and earlier. And so that's why we're seeing more of them. But I think there's a lot of data supporting that prevalence of OSA could be increasing, one, just because of the obesity epidemic. We see that significantly in the US, and I know other countries around the world have seen that as well. But also, there's more and more data showing that there's a lot of craniofacial underdevelopment. And so over the last several hundred years, our faces are, quote, shrinking. And so we see a lot more retrognathia, transverse maxillary deficiency, or a narrow upper jaw. And that's why, especially in patients that are younger or thinner that have sleep apnea, usually it's some kind of structural issue. The most important thing when we think about, treating it. So, my specialty is treating CPAP alternatives, and basically every single patient has some form of anatomic obstruction leading to this. But it's really important to realize that that is not the only factor contributing to sleep apnea. And so if we see a structural issue and we only address that, and we're missing some of the other factors that are causing sleep apnea, then that can lead to patients having kind of not fully treated sleep apnea. So other factors include things like poor muscle tone of the upper airway. So as we get older, the muscle tone of the airway decreases. And so that's why things, especially like hypoglossal nerve stimulation, has been a really important factor, particularly in older patients. Something called high loop gain, which is a more complex kind of physiologic mechanism where patients will be having apneic episodes and their carbon dioxide levels kind of drop. And then instead of just breathing and coming back up to normal, they overshoot and they end up hyperventilating. Their CO2 gets too low, and then all of a sudden it causes them to have these kind of unstable ventilations. And so that can contribute to sleep apnea, although that's more commonly seen in patients with significant cardiovascular disease. And then low respiratory arousal threshold. So we think of these patients as the light sleepers. So people that are very easily aroused. And so even mild disturbances in breathing can cause them to have arousals leading to sleep apnea. And so again, it's really important that we're kind of looking at these patients from the entire clinical picture. And that's why, the answer is not always, one size fits all, or this patient just needs an MMA, or this patient just needs a tonsillectomy. Usually there's multiple factors that we need to address to fully treat a patient. So this is a sleep surgery algorithm that I've kind of adapted from Raj Dady at the University of Pennsylvania, where I trained, and kind of made some adjustments. But when I'm looking at patients for sleep apnea, there's a lot of different things that we can do to treat them. And this isn't the focus on the talk, but I wanted to kind of just give everyone a brief overview. So, you think if they're CPAP intolerant, can we fix something structurally? If they have, nasal obstruction, can we just do a nasal surgery? If they have some kind of significant maxillary expansion. Let's see if I can get a pointer on here. That's all right. Can you see my arrow prayer on the screen?
Yes.
Okay, good.
Yes.
So you can think if they have a narrow palate, you can think of doing an expansion, which we'll talk about, or a maxillary expansion. And then we kind of get down into, once we do a drug-induced sleep endoscopy, we look at what kind of surgical interventions can we have. And specifically, when we look at the surgical interventions, we think of if they have primarily soft palate collapse, we can think about pharyngoplasty. Sometimes we can think about neurostimulation. If they have very severe lateral wall collapse, one thing I don't include in here, but weight loss can play a big role in lateral wall collapse. Pharyngoplasty, but maxillomandibular advancement, or MMA, which is what I'll call it, is very effective for this. Tongue-based collapse, there's a whole host of different interventions. And then if you have what's called multi-level collapse, if you have collapse at multiple levels, then MMA can be a highly effective treatment option for that. And then for tongue-based in particular, things like genioglossus advancement or maxillary expansion can be effective. So we're going to get into maxillomandibular advancement surgery now. And this is, at the beginning, is going to be kind of a more broad overview of MMA surgery. And then we're going to kind of get into more of the details during the case presentations. But when we think about MMA surgery, we think about the 3 Bs. Breathing, for me, is the most important thing. So I come from a sleep surgery background. So improving sleep disordered breathing is kind of my #1 focus when I think about doing an MMA surgery. We think about their bite. So if they have a great bite ahead of time, we want to maintain their preoperative occlusion. If they have some kind of malocclusion, overbite, underjet, overjet, whatever that might be, we can fix their bite at the same time as their MMA surgery. And then it's important to, maintain facial balance or improve facial balance. So it used to be called beauty, but now we think maybe that B is not as politically correct. So we change it to facial balance. And so we want to see, what is the maximum amount of advancement that we can do of the maxillomandibular complex while still maintaining facial balance. So one of the things that has revolutionized skeletal surgery is virtual surgical planning. And, this is something that, because I'm younger in my career, this is all I know. So I know, people that have been doing this a long time before virtual surgical planning happened. You were very, incredibly skilled with doing all the measurements with calipers and all of these different things. But now the technology is getting so good that we can basically pre-plan all of these surgeries. And so this is an example of one of the images we get during our VSP planning. So we can plan exactly what our mandibular gap is going to be. Depending on how far we're advancing, we can see if there's going to be any potential interferences of the bone. We can trace out where the inferior alveolar nerve is going to be running through the bone to make sure that we plan out our cuts accordingly. In my practice, I use 3D printed cutting guides and plates, particularly in the maxilla. So these are an example of the 3D printed maxillary plates where, once we expose the maxillary face, you can put on these plates, you can pre-drill all of the holes where we're going to place our screws. And we already have the cut line where we're going to do our Lefort osteotomy on either side. And so once we down fracture and advance and make sure that we have kind of a freely mobile segment, then essentially all we're doing is bringing in these pre-bent plates where we can now just screw them into place and we have the maxilla in the position that we want it to be in. The mandible is a little bit more complex. So I still use mandibular cutting guides. I think it's just, for me, is efficient. So this is a tooth-borne cutting guide. I use a company called Synthes to make all these, but the tooth-borne guides I found are a lot less bulky and they can be much smaller than the ones that initially would just try to contour to the mandible. So because they're tooth-borne, they can be custom molded to the teeth. And so the only two things I typically use this for is it just gives me a quick cut where I want the segment to be. And so we can plan out where the mental foramen is and decide, how anterior we want to make this lateral cut. And then I also use it to pre-plan. Usually I make my medial corticotomy about 2 to 3 millimeters above the lingula, and that can all be planned out during the surgical planning. This is an example of a 3D printed mandibular plate. I don't typically use these only because there's a lot of variability, and I think the software is still not good enough to say, if the CT scan taken preoperatively, the condyle is not perfectly seated, or they're not their bite is not in centric relation, then these plates don't fit perfectly. So I still, once I have the condyle seated, I will just bend mandibular plates on my own. So I typically do the maxilla first because those custom 3D printed plates will give pretty good reliability on maxillary position. And then once I do my bilateral sagittal split osteotomies, you can lock the mandible in place, and then we just kind of bend the plates to plate accordingly. Everybody has different thoughts on this. Because I'm typically doing pretty large advancements for patients with sleep apnea, I will typically use a monocortical plate with about 2 screws monocortically on each side, and then I will still do 2 bicortical fixation screws to just give them very, very rigid fixation. Because again, I worry with big advancements, even with 2 monocortical plates, that some of these patients that typically have bruxism, they have a lot of tense musculature with their sleep apnea. So we make sure that they have, again, good fixation. So again, this is just an example kind of a 3D representation post-operatively of a MMA. So on the left, you can see kind of the pre-planned, and then on the right is their post-op 3D reconstruction. So, the systematic reviews and meta-analyses show that MMA surgery is the most effective surgical option that we have for sleep apnea, which is good because it's also the most invasive. And if it was most invasive and didn't work very well, then I think very few patients would want to go through with it. But of these studies, you can see significant reductions in AHI, about 80%. We have significant improvements in the Epworth Sleepiness Scale, which is ESS. So we get pre and post-op patient questionnaires to determine kind of quality of life improvement. We see high rates of surgical success, and that's typically from what's called the modified Sher criteria, which is a reduction in sleep apnea by about 50%, and then their residual AHI less than 15, so high rates. And then about 40% of these patients will have an AHI less than 5. So we're going to come back to that in a little bit, but I want to focus now a little bit more on maxillary expansion. So, maxillary expansion in the past has been focused mostly on the pediatric population. So we know that we can do palate expanders in children. Usually they can be tooth-borne, and the maxilla is still pretty moldable. It's like a ball of clay at that time, so you can kind of make it whatever shape you want. But once we get to adults, once you have suture, interdigitation or kind of fusing in adults, then it becomes much more challenging. So, Dr. Stanley Liu, who was previously at Stanford and is now in Florida, had taken the surgically assisted rapid palatal expansion, or SARPE, from oral surgery world and brought it into, well, how can we use this type of procedure to improve nasal breathing and obstructive sleep apnea? So in 2017, he kind of incorporated this modified SARPE technique, which he called DOME, distraction osteogenesis maxillary expansion. And it was patients that had OSA, a narrow high arch palate, and nasal obstruction. And So what he would do would be a midline kind of osteotomy. He would make kind of a thin Lafort cut, just kind of scoring the bone and plus or minus releasing the pterygomaxillary sutures. And then you can see with this bone anchored expander. So it wasn't typically tooth borne, it was bone borne. And you could see, taking a patient from a very narrow, high arched palate to a very broad palate and expanding both the nasal cavity and the maxilla itself. And so in the initial pilot study that he had presented, he had a mean age of 30, PAP intolerant patients. They had a narrow palate. Their Mallampati was typically 3 or 4. And what he found was pretty significant improvements in their AHI just from expanding their maxilla. So he saw about a 50% improvement in the AHI. He saw improvements in the Epworth Sleepiness Score. The nose score is the nasal obstruction septoplasty effectiveness score. And so that's a tool that we use to measure kind of nasal obstruction. And so very significant improvements in nasal breathing and expansion of the nasal floor. And so then specifically on airway, Dr. Liu had, published a follow-up paper showing that by expanding the maxilla, you're expanding the entire nasal airway and improving the nasal valve. And so this is one of the reasons why, he thinks that the nasal breathing improved so much. And so these patients had on average an increase of about 2.5 degrees at the nasal valve angle, which is pretty substantial. And that correlated directly with the amount of improvement in nose score. So, the more they expanded, the more the nasal valve improved, the more improvement in nasal breathing that we found. And, interestingly, in the ENT world, we focus a lot on sinus surgery, septoplasty, turbinate reduction. But we know there's increasing literature that shows that, if the patient doesn't have the right phenotype, it doesn't matter how much you rearrange the furniture in the room. If the room is too small to begin with, then it's not necessarily going to improve. So if the nasal cavity is, I tell people it's like a studio apartment. If the maxilla is so small that the room is too small, then even if you do a septoplasty, turbinate reduction, sinus surgery, that patient is likely to have persistent post-op nasal obstruction. And so what Dr. Liu did in this paper was essentially take those patients and then do a dome on them and found that essentially resolved their nasal obstruction. So the furniture had been rearranged, and now he moved them from a studio into a 3-bedroom apartment, and they were able to breathe well. So, why does maxillary expansion work? One of the main focuses is that it decreases nasal resistance. And so by expanding at the internal nasal valve, by expanding the width of the nasal cavity, it decreases nasal resistance. And so by doing that, you think we have less kind of negative pressure in the pharyngeal airway. And so if you don't have as much resistance in the nose, the tissues in the back of the throat may be less likely to collapse. The other thing is that it improves maxillary arch width. And so now if the patient has room for their tongue to sit, then maybe it can sit farther forward and you have less rates of tongue base collapse if the maxilla is more open, and then you can also improve kind of proper lip sealing. And then, we're also increasing the oropharyngeal space and potentially improving tension on the lateral wall. So those lateral walls are also attached to the maxilla. If the posterior maxilla is expanded, perhaps that is another factor in terms of why it helps with nasal breathing and OSA. So, the 2-pen is while I was a fellow at the University of Pennsylvania, we, basically created kind of a hybrid dome technique, which is called posterior palatal expansion, so 2 Ps, with subnasal endoscopy. And so what we did, and I'm going to show you, is basically a way to, instead of just kind of separating the mid-palatal suture in the very front between the teeth, we would endoscopically cut the entire mid-palatal suture from above, from the anterior nasal spine all the way to the posterior nasal spine to ensure kind of full separation. So we can use full surgical planning with these. And so you can see that this patient had 4 TADs or screws, and you can actually see the holes in the maxilla when looking from above and see what the length of the maxilla is. One of the things that is, a big question mark still in the world of kind of SARPI, especially for OSA, and especially when we're trying to get more and more minimally invasive, is, what is the fewest amount of cuts that we can make to expand someone? because perhaps not everybody needs a full SARPE. Some patients may only need a mid-palatal suture cut. Some patients might need mid-palatal suture plus the lateral buttress. Some people might need, variations of these. And so studying bone density heat mapping, among other things, is a way that we're trying to figure out, can we custom design these interventions so that it's not necessarily a one size fits all. I also use tooth-borne cutting guides, and so this is an example of a very small guide where I can just make a midline incision, and it shows me exactly where the central incisor tooth roots are, so I can cut right between here. It can show me with the pre-op virtual surgical planning, making sure that my lateral cuts are about 5 millimeters above any tooth roots. And then these are some custom plate cutting guides that I designed with the Synthes company, where basically we can do this through 3 small incisions, where I just cut the mid-palatal suture, and I just take a little wedge out of the lateral buttress because I find that's a really thick part of bone that sometimes can prevent patients from expanding. So this is a video that I put together in terms of kind of the technique that I use, and so this is just making a small incision in the midline, just from the lateral border of the central incisor to central incisor. And so once the bone is exposed, this is the tooth-borne cutting guide. And so I take a piezo saw and just cut right between the central incisor roots. And once it's marked, then I can take out the cutting guide and kind of complete my cut. And now what I've done is from the place in the mouth, I've actually raised the entire floor of the nasal cavity up. So we're actually looking, all of this right here is the nasal floor mucosa. And once we have this, we see the full superior aspect from above of the maxilla. And so I'm cutting the entire mid-palatal suture from the posterior nasal spine to the anterior nasal spine. And then you can basically just lay the carpet back down along with the septum. So you can ensure that the entire mid-palatal suture is cut. And then here I'm just making a small incision laterally. And then we're going to fit in the cutting guide laterally to get to the lateral buttress. So this is cutting, just a very small wedge out of the lateral buttress to make sure we don't have any significant resistance. So here's a small wedge of the right lateral buttress. And then we do the same thing with the left lateral buttress. And then I bring in a pterygomaxillary osteotome and separate the pterygomaxillary suture. And then once all the sutures are cut, then we can turn the expander. So that's the technique that I'm currently employing. And I found that I've gotten pretty reliable expansion, kind of doing not a full kind of Lefort cut. So you leave the medial buttresses intact. So the hope is that you get even more improved kind of nasal expansion. So the 2-pen results that we published a couple years ago showed, significant expansion at the posterior nasal spine, in the intermolar width, in the piriform width, and it showed that the patients had a nose score decrease from 57 to 14 by expanding their maxilla. So, similar improvements as the dome. The big thing that's been interesting is, as technology improves from an orthodontic perspective, now there are companies that are making these 3D printed, patient customized expanders where you can have multiple TADs. So this one has 6 different screws where you can plan out exactly where the thickest bone is. There is a little bit of tooth-borne anchorage, which is used to kind of compress the teeth. This one is called the tiger screw. So this is from Partners Dental Studio, which I commonly work with. And what we're finding is that it's not just patients, especially in men under the age of 25, that we can expand. There's been pretty decent amounts of surgical or non-surgical maxillary expansion, in men, up to the age of 50 or more, and almost all women are able to expand non-surgically. So, in my career so far, I have done 0 maxillary expansion surgeries on women, just because they've had so much success expanding non-surgically. So just a quick example, so this is a 35-year-old male. So you might think, okay, they're too old, their sutures fused. They had nasal obstruction. They had a straight septum, no significant turbinate hypertrophy. They had a narrow high arch palate. And so they underwent a MARPE, or a mini screw assisted rapid palatal expander with 6 different TADs. You can see the 4 in the midline, and there were also 2 kind of into the inferior alveolar bone into the inferior alveolar bone laterally. And you can see pretty significant improvements. So this is post-expansion. There was a 4 millimeter increase in the piriform width. And you can see just the amount of space and airflow inside the nasal cavity. The floor of the nasal cavity expanded about 4 millimeters at the same time. And then the maxillary teeth expanded 8 millimeters. So significant improvement in intraoral volume. And this was me. So this was my own self-experimentation here. So I had significant improvements in nasal breathing. I did this about 3 years ago now. Sleep quality improved. I ran a 10K race with my wife a few years ago and could breathe through my nose the entire race. And very fortunate that I was already, married with kids, and my wife decided not to leave me during this time until I closed the gap orthodontically. But I think this is a very exciting, time in orthodontics, because if we can, expand some of these patients non-surgically, then, it decreases, some of the substantial risk involved with surgery. If we end up going on to second stage MMA, there's less scarring, and might be more straightforward. So this is something that we'll continue to monitor and follow and see, how much can we change the craniofacial skeleton with less invasive options. So this is just an example of kind of the pre and post. And so you can see I had kind of a more narrow maxilla, a more narrow smile. What some of the orthodontists talk about is these dark spaces, on each side. So when a patient smiles, you can tell if they have a more narrow maxilla. And so you can see pretty significant difference in my maxilla pre and post expansion here. Okay, so I have about 10 minutes left, and for the last 10 minutes, I'm just going to run through a couple of interesting cases that I've had, and then we'll take some time to talk with our panelists and answer any questions here. So this is a patient who was a 46-year-old female. She had very severe OSA. AHI was 54. Diagnosed already in her 20s. So pretty young. She was relatively thin. She tried an oral appliance, but developed TMJ and discomfort with that, temporomandibular joint pain. She had severe CPAP intolerance, could not, tolerate using the CPAP regularly. And she underwent, with an outside surgeon, she underwent a septoplasty. She underwent a UPPP. After this, she continued to have persistent severe OSA. So her AHI at that time was 54. And then, went to another provider and was implanted with hypoglossal nerve stimulator implant in 2020.
Hello? Assalamualaikum ji.
Even with the Inspire device, she had a titration study which showed that it was having pretty minimal improvements in her sleep disordered breathing. So even with Inspire, she was having persistent fatigue, daytime sleepiness, snoring, and quality of life was very poor. And so you can see here, in the pre-op photos, when I saw her, she had a pretty forward head posture. She had a cant, and so her occlusion was off. You can see she has a pretty steep plane of occlusion, significant retrognathia. And so I took her to the operating room to do a DICE. So I did a drug-induced sleep endoscopy. And what I found was that she had pretty severe base of tongue collapse. And 2 anterior posterior collapse are complete. And so you'd think, okay, well, this is the ideal Inspire candidate to, complete base of tongue collapse. She's a 46-year-old female. She's not significantly overweight. But I tested the Inspire at all configurations during my sleep endoscopy. So I did a bunch of configuration changes, and it basically did nothing. She was having severe mouth breathing still, persistent tongue-based collapse. No matter how high I turned up the Inspire, it was not improving her airway. So I talked to her, and the decision was made that given her significant retrognathia, given she still had very severe sleep apnea, my recommendation would be to move forward with MMA. And so what we did was planned a 12-degree counterclockwise rotation. So with how steep her occlusal plane is, it allowed us to rotate the maxilla. We did an 8 millimeter maxillary advancement. We ended up doing a two-piece Lefort because she had an asymmetric crossbite. So we just did a left-sided kind of two-piece to move her to be able to fix her occlusion at the same time. And then we did a 4 mm genioglossus advancement with correcting the cant and yaw that she had. And so, this was her postoperatively, and her AHI ended up going from 54 to 5. And fatigue, daytime sleepiness, snoring resolved, and had a really significant improvement just in general in quality of life, and has been doing great. So, we actually decided some patients would say, well, okay, I'm not using the Inspire anymore. Why don't you just go take it out? But given the fact that she's already 46, and there's a chance that, based on muscle tone and other things that arise, we just decided to leave it in so that if she starts developing snoring or slight worsening in sleep apnea, that we always have it to reactivate that to improve the muscle tone of her airway now that her jaw structure has been improved. So she had a really, really nice outcome. This is an example of multimodal therapy. So thinking about different options. So this was another 46-year-old gentleman. He had a history of reflux, anxiety, depression. He had significant chronic sinusitis. He had a functional endoscopic sinus surgery and septoplasty, and had pretty severe OSA. And he was worked up by another surgeon who ended up doing Inspire on him. And unfortunately, his AHI did not improve much. So he went from an AHI of 74 to 68 with the Inspire implant. Still had very severe symptoms, fatigue, sleepiness, snoring. A lot of these things were likely worsening anxiety and depression with him. So I took him to the operating room again for a sleep endoscopy, and I turned the Inspire device on. At baseline, he had pretty severe lateral wall collapse, which we know that is not a good indicator for hypoglossal nerve stimulator implantation, and also had pretty significant tongue-based collapse. And when I turned the Inspire on, despite whatever changes or configurations I changed with it, really did not show much improvement in the airway. And so, what we did for him was he ended up doing an MMA, and we did a 10 mm maxillary advancement. We did a very slight counterclockwise rotation on him, and interestingly, his BMI was 30, so he's was heavier, so he didn't really improve as much as I had hoped he would. So his AHI went from 68 to 28, so definitely better. Symptoms were significantly better. Snoring was much improved, but his AHI was still 28. And so what we did was he still had his Inspire in, and so we recalibrated it. And because now his airway was so much more open with the MMA, we could actually turn down the voltage pretty significantly with the Inspire, and so he tolerated it much better. Again, his AHI, is not perfect. It went from 68 down to 18 with MMA and Inspire, but his symptoms are completely resolved. And our next focus with him is just kind of getting his weight a little bit into a more normal range, and that will hopefully help resolve the remaining sleep disordered breathing. But this is an example of a patient where, he probably has a component of muscle tone with this as well. And so an MMA did not resolve his symptoms, completely on its own. And so this is kind of combination therapy. So MMA, he needs Inspire, he's got to work on weight loss, and hopefully with all of these things combined, we'll get him into a much better place. But fortunately for him, his symptoms are much, much improved. The big question that we have kind of moving forward is, especially now that we're doing a lot of expansions in patients. So, if we're doing maxillary expansions, do we do this in one stage where we do a multi-piece Lefort and we can expand the maxilla as we move them forward? Or do we consider two-stage where first stage is expanding, second stage is advancing? So this is a 30-year-old gentleman with past medical history of moderate OSA. His AHI was 20. He had periodic limb movements and significant nasal obstruction. So his nose score was 80 out of 100. So really significant nasal breathing issues. He already had a relatively straight septum. He could not tolerate CPAP with a nasal mask because of his nasal obstruction, and was struggling with full face mask. He had tried oral appliance therapy, but again, developed some temporomandibular joint discomfort. And so I took him for a sleep endoscopy, which demonstrated pretty significant base of tongue collapse. And so for him, he had a pretty narrow high arch palate. He essentially had a crossbite because his lower teeth were tipped inwards on the mandible. And so they were kind of dentally compensating for his narrow maxilla. So with his nasal obstruction, we talked, there's a couple different ways that we could treat you. He was bimaxillary deficient, but he also had this narrow palate. So we decided to do maxillary expansion on him for the first stage. So he had a really nice expansion. So you can see from pre-op to post-op, he had about 8 millimeters of expansion at the first molars. Nose score really significantly improved from 80 down to 15. But interestingly, his sleep apnea still didn't improve too much more. So he went from an HI of 20 to 18 post-operatively, but now he's tolerating a CPAP with a nasal mask. But considering how young he is, he was like, I really want to try to see if we can resolve this long term. And so he decided, given that he still was bimaxillary deficient, that we went on to a second stage MMA. And so he ended up having a 10 millimeter maxillary advancement. He had a pretty flat plane of occlusion, so we did not significantly rotate him. But his HI went from 20 to 18 with the maxillary expansion down to 2 following MMA, and his remaining nasal obstruction resolved completely post-operatively. So he had a really nice result. And then this is another case. So, this is a 54-year-old patient, history of obesity. He had an BMI of 39, so definitely heavier, and pretty severe sleep apnea. So his AHI was 43, his supine AHI was 66. He had tried CPAP on multiple attempts over, a period of 15 years, but could not tolerate it. And so continued to be severely fatigued. He had unrefreshing sleep. He was drinking 4 to 5 cups of coffee daily just to try to function. His nose score was not significant, so he didn't really complain much of kind of nasal breathing issues. But when I took him for a sleep endoscopy to kind of as part of the workup, he showed kind of partial concentric collapse at the soft palate and pretty severe complete lateral wall collapse. So, decision for him, given that he did not have significant nasal, obstruction, given the fact that he also was the kind of guy that said, I don't want to, do this over 2 years. I want to just get this all done at once. I can't afford to do all these things over a period of time. He wanted to have everything done at one time. So we did a 3-piece Lefort. We did a 10 millimeter maxillary advancement without any rotation because, again, he already had a relatively flat occlusal plane. And his AHI went from 43 to 12 and supine AHI 66 down to 12. And pretty amazingly, he came in at his 3-month follow-up and he's like, I have not had a cup of coffee since surgery. He wakes up, he's refreshed, he's got great energy levels. His sleep apnea is not fully resolved, but a big part of that we talked about is also weight. And so he started one of the GLP-1s, which if you're not familiar, are these medications like Zepbound or Ozempic to help with weight loss. And so he's working on that as kind of the primary. And we left him with a little bit of, posterior open bite because he's going to have some restorative dentistry work here. But really, really nice improvement pre and post-op, and was very happy with his results. So again, one of the things I thought about for him was because he didn't have as much nasal obstruction, aside from the fact that he wasn't necessarily interested in palate expansion, but this is a patient that was probably better suited to go straight to MMA with a 3-piece maxilla. So I think I'm almost on time here. So, I know that was a lot of information, but I wanted to also take time to kind of talk through with our wonderful panelists here. So the most important thing from, the takeaway, skeletal surgery is highly effective intervention. This is, I do a lot of different types of surgery for sleep apnea. This is the one I'm most passionate about because I think, we're physically changing the structure of the upper airway on a permanent basis and really having significant improvements in people's quality of life. When it comes to maxillary expansion, I think it should definitely be considered, in a subset of patients. It's not for everybody. So every single patient that walks in the office, I don't recommend palate expansion for, but especially ones that have, pretty significant nasal obstruction. They might have a narrow high arch palate. They might have a crossbite. If they have a very narrowed piriform width, those are the patients that I consider saying, hey, we should really do this first and see how we respond. And then, the big question that we still have in the field is, 1 versus 2 stage with multi-piece Lefort versus expanding. And so, again, if we have patients that are these candidates for maxillary expansion, sometimes they might be better suited to say, well, why don't we expand the entire maxilla and then bring everything forward as a one-piece Le Fort where we can improve nasal breathing and then also improve the entire pharyngeal airway from top to bottom with MMA. And then the last take-home point is, to a hammer, everything's a nail. So just because a patient has these skeletal deficiencies doesn't necessarily mean that that's the only driver of their sleep apnea. So it's really important to, try to recognize, are there other factors that are also contributing? So MMA alone may not be the only option. Maybe they'll still need Inspire. Maybe they'll still need tonsillectomy or pharyngoplasty, treatment of their nasal obstruction. They might have comorbid insomnia, restless legs that can, affect that. And just making sure we're looking at the patient from kind of a fully global view is how we're going to end up getting the best outcomes and the happiest patients. So that's all I have. Thank you so much. I know that was a lot, but I really appreciate everyone's time and attention.
Thank you so much, Professor Hutz, for this amazing lecture and also for showing us your thinking process, for walking us through your thinking process. So at this time, I'd like to invite our panelists for some discussion. So the first panelist that I'd like to invite is Dr. Roden.
Hey, how are you? Is there certain questions, comments?
Oh, Dr. Roden, you can start by saying whether you have any comments for Dr. Hutz or whether there's any questions that you like to ask him or just anything in general.
Yeah. And Dr. Roden, I mean, you have the unique perspective of having done the same fellowship that I did at Penn and then also the Stanford fellowship. So you are very, very well versed in lots of different aspects of skeletal surgery here.
Yes, and also Dr. Roden, if you have any perspective that you like to add, and that'd be perfect too. Just anything in general. Yeah.
Yeah, no, thank you all for having me. I think probably because Mike and I did, similar training at Penn. I think we have similar philosophies in terms of, patient selection for OSA and who should undergo, SARPI and or MMA. So I definitely, agree with him that it's, select patients. It's not for everyone. I would say similarly to what Dr. Hutz had said was, we do MMA, I'd say more so in patients who already have underlying dentofacial, abnormalities, deficiencies. Obviously, it's in younger patients also, it's a lot more common for us. And then additionally, we do it, as salvage in those patients, similar to some of the examples that he gave with, those patients who had failed, modified UPPP, failed hypoglossal nerve stimulation, and they want a treatment, they can't tolerate CPAP, and they're really sleepy and they're really struggling. So I think in those cases, it's a really great option. I think, in general, we don't do segmentals very commonly or because similar to what Dr. Hutz was talking about, we're really doing these big movements at the maxilla, and then we're also counterclockwise rotating them. So it's a lot of movement. And so I think, in these patients who often are, pretty narrow, you have to expand them a lot as well. And so I don't know if there's been like much in terms of, literature on this, but we're a little bit worried that with the maxilla already being in multiple pieces and then those really big movements forward, that it might be a little bit unstable and you worry about, it relapsing back or not being, perfect. And so we tend to, if we're going to expand them, we either do BARP or SARPI beforehand. And then once they're healed from that perspective, then we'll move them forward.
And I think just to comment, Dr. Roden, too, is, the one patient that I showed that she had, every sleep surgery under the sun. If I had seen her in her 20s, maybe I would have recommended MMA right off the bat, but she may not have been ready for that. So, it's not a disservice to any of the other surgeons that took care of her. She might have said, give me the least invasive options you have, and done her nasal surgery and then did a UPPP and then did Inspire and then finally came to the realization of like, I just need to go with, the bazooka, the MMA to fully fix things. Or maybe she would have, but a lot of times, MMA is a tough sell for a lot of patients. There's a lot of patients I recommend it to. There's, it's only a small fraction that are willing to, let me break their face and put it back together. So, sometimes it takes them this journey of treatment failures. So it's not necessarily taking away from the decisions that other surgeons offered. They might not have been ready, psychologically to take that step before they failed some of these more conservative options.
Yeah, no, absolutely agree. I had somebody the other week who, we had talked about the pros and cons of everything, and they were just like, I'm not ready and wanted to do, Inspire first. And so that's our plan for them. And then, but we have, MMA in our back pocket if it does not work out. I also have those patients though who say like, I just want, like you said, the bazooka. I just want one surgery and I want to be done. And then you kind of counsel them, well, probably MMA is, the best option. Or I have those patients that say, with Inspire, you always have to, turn it on when you're asleep and just if they fall asleep on the plane, if they fall asleep on the beach, they want to just be able to sleep and not worry about someone saying like, who's that loud snorer over there. And so that's another one where I feel like some patients want to just have the fix and then not have to worry about everything else. And also sometimes we do see those patients who, as in the picture for your one patient who had tried everything before MMA, who is forward leaning. And so I feel like we also give these patients daytime relief, and which they don't always notice kind of how they're compensating with their posture to help open up the back of their airway when they're already severely retinopathic. So that's something else that they just feel better during the day, and it's not even just necessarily a nighttime treatment.
Yeah, it's pretty amazing looking at post-op MMA pictures, and a lot of people's neck posture improves significantly subconsciously. Once they have a good airway, they're straight up and down. They're not kind of, leaning forward subconsciously to help them breathe better. And it does take a lot of kind of tension and neck pain off in a lot of these patients post-operatively.
May I ask a question to both of you? Because for me, I'm a dentist. I'm pretty like that. When we talk about OSA, we should consider from the nose, not only for the jaw and occlusion and due to the tongue. Because I think in some alternative training, when we talk about MMAs, like such as when we have the topic about MMA, sometimes we only focus on the jaw and the occlusion. So may I ask about the maxillary expansion? Who designed to do? Just in case if patient don't have the crossbite anymore, but they might have some problem about nose or something. May I ask, like in your practice, who decide to do suggest the patient to do the maxillary expansion? Because some case they might not need, right?
Go ahead, Dr. Roden.
Yeah, I'd say, yeah, great question. In general, we do it, patients who do have some sort of, malocclusion that you see it, whether there is a crossbite or not, or you can tell that, they're either like lingually or buccally tipped to help compensate. Also just, we get CTs on all of our patients. So, doing the measurements and seeing what their IMD is in general, if it's less than 30 millimeters, it's consistent with a transverse maxillary deficiency. And then also kind of the nasal complaints. So that's another thing as well as trying to improve that is trying to improve their nasal breathing and just tongue positioning. Sometimes also similarly to what Dr. Hutz commented on with, if we do a dice on them and, we notice all these we do the measurements, we kind of see that they're high arched or they're narrow or they're having some sort of malocclusion. And then we're also seeing this tongue-based collapse. And, we're thinking the tongue's probably just not fitting well. And their maxilla as well would be another inkling. I'm similarly where now that I feel like with MARPE, so many people can expand non-surgically. I try to get them to, go that route unless they also have like a significantly deviated septum or something like that. Then I'll maybe do SARPE, so I can address that at the same time. But otherwise, I've been trying to, push people to do non-surgically, at least right now, to help kind of, prevent any other surgical complications and or scarring if we do MMA later down the road.
Yeah, I agree. I mean, I work with a really excellent orthodontist, Yiwei Huang is his name. He's in Chicago with me, and he does a lot of MARPE. And so he'll refer me a lot of patients, and so he'll already recognize, hey, we have this transverse deficiency with nasal obstruction, and so they already come to me knowing like they probably need some kind of expansion. But again, we can only expand the maxilla as much as the lower dental arch gives us. And so, once you upright the lower teeth, we're limited by that unless you start thinking about things like SFOT or surgically facilitated orthodontic treatment. So I have George Mandelaris is a kind of a world-renowned periodontist that's in Chicago with me that does bone grafting. So, theoretically you could, add bone to the lower jaw and then expand the teeth out, but then we're kind of, layering on all these different treatments. So, I will frequently recommend patients to try, MARPE first. And similar to Dr. Roden in my practice, I recommend almost everybody try non-surgical first because, Dr. Huang and I have a protocol where if they have a custom 3D printed MARPE, say, hey, turn daily for 3 weeks. And if we see a diastema and a split, great, you can proceed. If you don't see a split, unturn it, and we'll plan to do a SARPE to expand. And so I think if we can get people to expand non-surgically with the technology, we should. The main issue that we find in the United States is that this can be extraordinarily expensive. And so MARPEs and the orthodontic treatment can range anywhere from $10,000 to $20,000 for patients, which is not typically covered by insurance. And so the issue becomes, are we only treating a subset of the population that can afford to do the palate expansion? That's a really big shortcoming in the United States right now to figure out how can we make this more affordable to bring these to patients.
Thank you so much. Thank you.
Yeah, great question.
Okay,
Thank you. Yeah, thank you, Dr. Roden. So next I'd like to invite Dr. Punkanson.
Okay. Thank you for the excellent talk. So I totally agree about that. Maxillary expansion can improve tongue bed collapse because I learned more from my patient that underwent dome surgery. Yes, almost patient. Actually, sometimes they cannot breathe. They still cannot breathe to the nose. It just improve a little bit. But the one thing that I learned that all of my patients confirm that they can breathe to the nose because they can close the mouth when sleep. The one thing that I learned from them, because as you know, because I'm ENT, many patients in Thailand have a problem about the chronic rhinitis. I also apply for the nasal surgery to correct about the septoplasty or also turbinoplasty that make they can breathe to the nose. And if the patient got the dome surgery, they also close the mouth when you sleep. That improve the OSA. So I think for this lecture, that confirm my idea, and I gonna continue to treat the patient. But one thing in Asian patient who often present with a narrow and also high art palate and also retrognatic mandible, and almost of them have also the prominent cheekbone. So I would like to learn from you or any idea from you that what would be your preferred strategy performing maxillary expansion, even SAPE or dome or two-pen first, and then MMA or proceeding directly with the 2 or 3 piece MMA because as you know, when the permanent cheekbone, we cannot at once for the maxilla piece, we cannot at once, it's too much. So even I do counterclockwise rotation, I cannot at one maxilla more than 6 millimeters. So that's why I concern that I have the patient that I underwent dome first and then followed by the MMA. So that the good for patient outcome, okay? But some patient ask me that, can I do one procedure? He don't want to do more surgery 2 times or maybe 3 times. So that's why I concern about this. And do you have any idea for share?
Yeah, so thank you for the question. Is the question how to do it as a one-stage surgery with a multi-piece Le Fort? or I guess if you could rephrase the question, I don't know if I fully understood.
Uh, do you think if we do the maxillary expansion first and then followed by MMA, because and compare with the 2 or 3 piece to get the wider maxilla in the transverse section,
Yeah.
which one do you have any idea for that?
Yeah, I mean, I think a lot of this is dictated by the patient. So even if you think this patient should have a two-stage procedure with, dome, SARPI plus MMA later, if the patient doesn't want that, you have to meet them where they are. And so those are the patients where, I think we might say, okay, well, maybe we won't get the same expansion at the nasal cavity up high that we get with dome. But when you do a three-piece, you're still expanding the nasal floor. And especially when you do the counterclockwise rotation, you're dropping the entire floor of the nasal cavity. And so it's really expanding the nose posteriorly. So anybody that I do, the one woman that I showed early on that had Inspire and all these other surgeries, a 12-degree counterclockwise rotation, post-operatively, she's like, I've never breathed better through my nose. I didn't touch her turbinates. I didn't touch her septum. Her nasal breathing is incredible now. And I think a big part of that is one, the counterclockwise rotation expands the posterior nasal cavity. But two, whenever I do this, I drill out the floor of the nasal cavity. So I really lower the floor of the nasal cavity. So I think it expands it, inferiorly as well. And you can widen the piriform rim. I use a pineapple burr during surgery to kind of significantly widen the nasal cavity. And I think they still have improvements. But part of it just depends. If they're not willing to do that, then you can do the best you can as a one-stage surgery with the understanding that, we might not get the same amount of, improvement in nasal breathing, but you do your best. Hopefully, did that answer your question?
Oh yes, yes. That about one thing that I concern that when the patient still have the narrow maxilla, and when we did the MMA for the patient also have the open mouth breathing.
Mhm.
Yes, that's why I concern that maybe that if the patient have the phenotype like the LEM OSA, they also still have worse in the LEM state when they sleep. So that's why I concern that should I expand first, but or maybe do 2 or 3 piece for make the wider maxilla. So
Yeah. So I think, I mean, if you're that narrow and they don't want to do an expansion, then, doing a three-piece will provide them the same, potentially similar amounts of oral cavity expansion and room for the tongue to sit. But just by bringing the jaw forward, you also are kind of pulling the tongue base forward as well. But I agree. I think focusing on mouth breathing during sleep is very important in these patients. And the patients that have persistent sleep apnea after nasal surgery, UPPP, Inspire failures, I find mouth breathing a really big part of that. I don't know, Dr. Roden, if you want to comment as well, but if you can, I jokingly say with patients, you got to shut your mouth, to keep your mouth closed during sleep. I think that certainly plays an important role. So whatever you can do to facilitate that, I agree, is very important.
thank you,
Yeah.
thank you.
I'll quickly comment on that as well. I think there's, one study that Hewitt's group did out of at Harvard where they showed that for the most part, if you close the mouth simply, these patients, improve dramatically. Their nasal flow is like a quick thing during DICE, but they did show about like, I think it was like 10 to 20% who, when you close their mouth, they actually got worse. And so there are these patients who, whether it be, so significant nasal resistance or something like that, that they just cannot overcome what's going on in their nose and they need to mouth breathe. Um, and yeah, and so if you can if you improve, their nasal resistance or something like that, then they'll get better. But there are as a caveat a few subset who just want to mouth breathe and that's their preferred route of breathing. But in general, we do sometimes see in these patients, even when we do move their lower jaws forward, and they, are really improved, still they have this component, even if their nasal breathing is much better, that we sometimes call it a slack jaw, where they just want to like open up their mouth. And so sometimes we will have patients, either use some sort of mouth closure device or chin strap just to help give them a little bit support to kind of retrain them and help to, close their mouth so they breathe better at nighttime.
Thank you so much, Dr. Juice. So may I mention about the mouth breathing because right now is quite a very hot issue for the dentists and orthodontists as well. Because so many ENTs in these sessions. So mouth breathing could be an early sign of the sleep disorder or OSA, both in children and adults. What do you think about that?
I apologize. Can you repeat your question?
Okay, because right now, about the mouth breathing is quite a hot issue among dentists.
Absolutely.
I could say that because I try to learn from Europe, in the US, and in Asia as well. So the question is about did you consider the mouth breathing could be the early sign for the sleep breathing disorder or OSA for the patients, like both in children and adults or not? Maybe it's quite a common thing that ENT knows, but I mean, among the dentists or even surgeons, we still have some thoughts about that, like what it should be. Thank you.
Yeah. I mean, one of our colleagues, Jason Yu, who also did a fellowship at Penn, who is now at Emory University in Atlanta, he did a really nice scoping review. So it was a very comprehensive review of the literature on kind of what factors contribute to craniofacial underdevelopment. And so, this was basically just reviewing thousands of articles that have been published, but certainly mouth breathing in children, we think contributes to, narrow high arch palate, these long adenoid facies with bimaxillary deficiency. So I think addressing mouth breathing in children, I think is really important. I'll sneak into my kid's bedroom when they're sleeping, and if their mouth's slightly open, I'll like close their lips while they're in there and make sure they're breathing through their nose during sleep. And I think appropriately treating allergies and all these different things to make sure kids are nasal breathing, I think is very valuable.
Thank you. So could it be the exercise like if we teach the children to close their mouth and try to breathe to the nose during the day, like make more conscious about the breathing? Don't you think
Yeah, that's certainly a part of it. I think we don't have enough data to show, that by itself is going to cure sleep app or, prevent sleep apnea long term. But I think there's more and more data showing the importance of nasal breathing for a lot of different reasons.
And may I ask more, how about the adult patient who have OSA with the mouth breathing? After you did lots of things such as Inspire or even the skeletal surgery or soft tissue surgery, the mouth breathing, does it improve or not? Like in your experience?
Yeah, great question. I think a lot of patients will mouth breathe if a patient breathes normally through their nose during the day, but mouth breathes at nighttime, that is probably because of their sleep apnea. So I don't think it's the driver of it, but if a patient breathes normally, as soon as they fall asleep, if their jaw, relaxes or their tissues fall back, then they end up opening their mouth to breathe. And so I think if you treat their sleep apnea or soft tissue or skeletal, deficiencies, then they're able to breathe through their nose during sleep. If a patient can't breathe through their nose during the day, then they're not going to be able to breathe through their nose at nighttime. But I do find that many patients that quote mouth breathe during sleep, that will improve if the cause of their sleep apnea is improved.
Okay, thank you so much. Yeah. How about your experience, Dr. Robbins and Dr. Nett? Like when you treat patients with the OSA, about their mouth breathing?
Yeah, I think I agree as well. In general, I think they improve. I still think, I do still think there's that small subgroup who will just open their mouth. I don't think, though, they're necessarily mouth breathing. I think their mouth just relaxes and opens. We've seen that a few times on our indices or our drug-induced sleep endoscopies that sometimes patients' mouth is just open, but the flow is going through their nose. And so some people think they're mouth breathing, but they might not necessarily be. But similarly, I think if you're, improving their jaw structure, and as Dr. Hutz said, if you're moving everything forward, they're going to have more room, retropalaty, retrolingually, to breathe in general.
Okay, thank you. Yeah.
Okay, and for me, I learned from the patient that when I do dice for the patient, and then when we use the scope to see the place that obstruction, and I also close the mouth the patient and look for that how improve of the airway. Actually, though, when we close the mouth, the airflow that pass to the nose is smaller than airflow to the pass through the mouth. So that's why the airways are always open. Someone has not too much open, but someone is bigger airway when we do the scope. And another thing that uh, even the patient use the CPAP for treat the OSA. But the if the patient also open mouth, they cannot use the CPAP because the air leakage. So sometimes I offer the dome procedure or maybe MAPE, maxillary expansion, for the patient to make them can close the mouth and also apply the CPAP. So as everybody know that the OSA treatment should be the personalized treatment. It's not only the CPAP or oral appliance or also surgery. We can combine all of that. That many options for the patient that we can decide together for the best outcome for the patient. That's why I learn and I try to confirm the patient to mix and personalize procedure for the patient. As I told you that maybe not only the CPAP alone, but combined with the surgery or maybe maxillary expansion with the non-surgical procedure can improve OSA. Thank you.
Thank you.
Okay.
Dr. Sudia, please.
Yeah, thank you. Last but not least, I'd like to invite Dr. Lee for some comments.
Yeah. Thank you, Professor Hutz, for your presentation. We've all learned a lot about MMAs and expansions, and congratulations on the good result for all of your cases. Those are very interesting cases. All right, so we're in Asia, most of our OSA patients are craniofacially restricted, as opposed to Caucasians who have predominantly a BMI issue. All right, so in Singapore where I work, a lot of our patients need skeletal surgery. So before embarking on my fellowship at Chang in Taiwan with Professor Clement, in Singapore, we used to do MMAs with upper and lower segmentals. So a multi-piece Lafort and an anterior segment with a BSSO. Because we find that if we advance the skeleton too much, our patients will look like a horse if it's just a single piece. But after coming back from my fellowship, Professor Clement always tells me that if you do a segmental surgery, you will lose the amount of traction that you can have on the dilator muscles. So a multi-piece Lafort is unable to pull on the dilator muscles as much as a single piece Lafort. So we've tried to avoid segmentals as much as possible. But for some patients, they are just too bimax. So the most we will do is a Lafort two-piece anterior segment to set back that anterior segment and pull the posterior segment of the mandible of the maxilla out. Yeah, so that's what I'm hoping to bring back to Singapore. And I'm hoping to work with Leonard So, who trained at UPenn.
Yeah, wonderful.
He's gonna bring in maxilla expansion into our protocol. So may I ask, in your experience, after having done the maxilla expansion, do you find it difficult to advance the maxilla because of any scarring? Are there any scarring issues post maxilla expansion or post 2-pen?
Yeah, great question. So, I will say the segmentals I only do out of necessity. So it's probably, 5 to 10% of all the MMAs that I do are segmental. So almost all of them we try to do as a one piece. And I agree for those exact reasons. I think it's more stable. I think it puts more tension on the dilator muscles. So that's a very excellent point. And some patients you just need to end up doing a multi-piece for various reasons. But I have not the main scarring that you get from doing a dome or two pen when you go back to do an MMA is really just in the front. So when you're raising, exposing the anterior face of the maxilla, that area is scarred because you've already made, those incisions there. But I don't find, after expanding this way, and Dr. Roden can comment, as well, but I don't find that doing a second stage MMA has significant scarring or tension where you cannot, mobilize the maxilla once it's been down fractured.
Mm-hmm. Right. All right. And
But yeah, I mean, I think doing the maxillary expansion first helps with that, right? So if you can do everything in a one piece, that would be my ideal world if I never have to do it, multi-piece Lefort. So if you can do that, I think that's great. It's just, again, based on cost and based on complexities of patients, sometimes you don't have an option other than doing a multi-piece Lefort.
Yeah. And can I also say that with the multi-piece Lefort, you're restricted by the soft tissue. So the amount you can expand is probably 6 millimeters, 7 millimeters. All right. Whereas if you do a MARP or a SARP, because you're expanding it slowly, you're allowing the soft tissue to grow, you can expand more than 10 millimeters from what I understand. So that could be a indication for, expansion first and then an MMA later.
Absolutely. Yeah, absolutely. Great point. So you cannot get the same amount of full expansion if you try to do multi-piece, even with a 3-piece Lefort, as you would get with expanding first, either non-surgical or with a surgery.
Yeah. And from what I understand, for indications for maxillar expansion, you look at it's a clinical judgment of a high arch narrow palate and a posterior crossbite. And I heard Prof. Rodin mention intermolar distance of 30 millimeters. Now, do you also look at the width of the nasal floor, where the terminates are, to determine whether you need to do a maxillar expansion or not? Because that's where you're trying to address. You're not really trying to address.
Yeah, excellent question. I don't think there's been any literature, at least that I've seen, and maybe people on the call can comment on, looking specifically at the piriform width to show what are normal, piriform widths. And I think it's going to depend on, probably, your gender, your race, all these different things. You could have varying options. I think not only a crossbite, but you can have a skeletal crossbite, right? So if you have dental compensation, they might look like they have normal occlusion, but their maxillary molars are flared out, their mandibular molars are tipped in. So if you just look, you say, oh, they have a class 1 occlusion. But if those mandibular molars are straight up, then they'll have posterior crossbite. So it's either an obvious posterior crossbite dentally or skeletally. I think is something to look at. And then certainly, if I've trained a lot of my facial plastic surgeons at Rush now, where if they see a really narrow piriform, they've started sending me those patients to say, I don't think right. And we're actually working on doing a clinical trial right now on rhinoplasty and the impact of kind of maxilla and nasal floor width, to see our patients that have a narrow nasal cavity may be doing worse with nasal valve surgery and septoplasty, rhinoplasty type procedures. And we don't necessarily have good data yet showing that, but I think intuitively, if you have a narrow piriform, again, same like I said earlier, if you're living in a studio apartment, no matter how much you rearrange the furniture, you're still in a studio. So, at what point do you try to expand things?
Yeah, that's right. Yeah, and well, we heard you talk about dome from Stanley Liu, and then there's a 2-pen technique as well, and there's Casey Lee's ease technique. So I think the main difference with Casey Lee's technique is that he focuses on the posterior part. So he expands the maxilla closer to the PNS. Do you think that makes a difference? Because from what I've seen in your slides, you're trying to achieve for equal expansion from the ANS to a PNS.
Yeah, I mean, I think in our results with 2-pen, I've been seeing fairly parallel expansion. I think as long as you're cutting the entire mid-palatal suture, which is what we do with 2-pen, I think we get similar kind of parallel expansion
Yeah,
with it. I think it depends a lot on the expander, and it depends a lot on where the TADs are placed. So if you have the expander placed too anteriorly, you're going to get probably more anterior expansion no matter what technique you use. If you have it where it's, maybe there's some molar bands posteriorly, or some TADs that you can, angle posteriorly, you can get kind of more parallel expansion. Um, but I think in reality, I think, we have all these different techniques. I think patients improve probably regardless of what type of expansion technique that you're doing. So, we've done domes, we've done 2-pen, and patients will improve kind of no matter what technique you do, I think.
yeah. But one interesting point is with Casey Lee's technique, his the diastema is not so wide because he's only expanding the posterior. So you don't have to go through the ugly duckling face. You shorten that ugly face.
Yeah. It's
Yeah,
hard to know. I mean, it sounds like the technique that he's published on, from what I've heard from patients, is not the technique he's using anymore. Because he's now switched to using, like, I think an FME type expander and some other
right.
kind of techniques where, so I'm not exactly sure what sutures he's cutting, and maybe Dr. Roden or anybody else on the call can comment. But I think it's because he doesn't cut the entire anterior maxilla, so that premaxilla is not fully cut between the tooth roots, that he kind of says, well, you're getting more posterior expansion. But the problem with the technique is if you have a patient with a crossbite, you don't really get intraoral volume expansion. So if you need the intraoral volume to expand significantly, the ease
Yeah,
is probably not going to give it to you. It might
yeah,
give you better nasal breathing, theoretically, but if you have a patient with a crossbite, their crossbite might not resolve if you're only expanding kind of in the mid face there. So I think, again, that's where it depends on what the patient needs. So,
yeah,
maybe one patient does better with a more limited ease type surgery. If you really need the molars to expand to increase intraoral volume for tongue position,
yeah,
in addition to nasal breathing, then I think things like maybe dome or 2-pen may be better indicated. But these are the topics that I love debating, because we don't have good data to support any of these things. We need to have some better, I think,
that's
trials,
right.
which are hard to do, to show, maybe one patient needs ease, maybe one patient needs 2-pen, maybe this patient needs dome if they need more, anterior expansion. So hard to say.
Yeah, what you really need is a multi-center study to compare the different dome versus 2-pen versus ease to see which one works out better. Okay, maybe one more question. Can I ask for MMAs, when you're doing your virtual surgical planning, uh, what 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 endpoints are you trying to achieve? For example, the A point, are you trying to get it more than 10 millimeters of advancement? B point, more than 10 millimeters, or the occlusal plane, you want to flatten it to 4 to 5 degrees. Generally,
Yeah,
those are the things I look at when I
Yeah,
choose.
great question. So, I think there's so many different things from an aesthetics perspective, and I think it probably is varying based on race and country and where you are. But for most of my patients, I train doing a full 10 millimeter maxillary advancement kind of across the board. In my practice now, usually I use, some people use like a vertical line from the Nasion to say this is where we're going to put the central incisors. Patients that I treat typically have pretty bad sleep apnea, so I use a vertical line from the glabella. So the soft tissue glabella straight down, and that's how far I advance. And so for most men, at least, you end up advancing probably around 8 to 10 millimeters on average. I try to flatten the occlusal plane anywhere from 3.5 to 5 degrees, typically. In some patients, if depending on their counterclockwise rotation, you may not end up needing a genioglossus advancement, and so you can potentially rotate them a couple degrees more or less. And I'll bring the chin forward to a point where it's basically a vertical line from the central incisors down,
Yeah,
typically, is where we end up with the chin. And so those are kind of the basics that we do. I think it's different for everybody. So if I see a patient that if I advance them 10, they're going to look a little more pronathic, but they have horrible sleep apnea and they're very, very symptomatic, then I'll often present that to the patient and say, hey, like this is what we can do to fully maximize your airway. From an aesthetic perspective, it might not be as ideal if we only advance you, 6 or 8 millimeters. And I let them decide. And some of them say, no, all I care about is breathing. Like even if I look slightly pronathic or jaws too far forward, that's okay with me. Some patients say, oh no, this is like, very, very, very important to me. Just advance me 6 to 8 millimeters.
Yeah, yeah. So it's a discussion with the patient.
Yeah, but this is actually an excellent question that Dr. Roden and I are doing a study right now. So we're putting together an MMA survey of surgeons that do skeletal surgery for sleep apnea to try to look at, because there's so much variability in how patients plan or how surgeons plan these. So everybody uses a different endpoint, like you said,
Yeah,
Lee.
exactly.
To say this is where we're going to put the teeth. This is how much we want to rotate, and so trying to get an idea of what surgeons are doing can be very highly variable.
Mhm. All right. All the best with your study. I think that's it from me. Thank you very much.
Yeah, thank you so much.
Thank you.
Yeah, thank you, Dr. Lee. And also thank you to all our panelists for our this very amazing discussion. However, due to the time restraint, so instead of doing a Q&A, we will probably end the webinar for now. However, I know that in the audience, a lot of people have questions for Professor Hutz. So is it possible if we can send the questions to Professor Hutz via email? And then perhaps after you answer them, we'll post it on our ICC group in Facebook for everyone.
Absolutely. I'd be
All
more than
right.
happy to answer any questions that pop up, and you can post them through Facebook.
All right. Thank you. So I guess we'll turn the host back to PY.
Thank you, Junior, and thank you, Michael, for your very comprehensive presentation about this. Nowadays, a very hot issues for all the patients with the OSAS. Even though I believe still a lot of dilemmas or lots of policy, we need a multimodal cooperation in between a lot of department away, like the plastic surgery, orthodontics, the ENT doctors, even the psychiatrists as well. We all have to devote ourselves to solve this problem together, not only by only one side. It's a very, very difficult issue to solve. Especially prior to any closing remark you want to present to our valuable panelists before our group photo. Hi, prior.
Yeah, I'm pretty impressed about Dr. Mike's presentations and all the panel discussions. Yeah, for me, I have learned a lot from the ENT side because as the dentist, sometimes we only focus on the jaw, but sometimes we forgot the nose and the tongue. Or even, I think we all know, like OSA is multifactorial factors, and the treatment should be like personalized, as you suggested about the treatment. It could be like the treatment modality could be like many ways. Yeah. And I learned a lot about the muscle tone as well. I think it's pretty very important because muscle tone might change due to the aging for the patient. So thank you so much again, Dr. Mike, for your excellent presentations. And thank you for all panelists who joined the sessions today, Dr. Robin, Dr. Ned, and also Dr. Lee. Yeah, thank you so much.
Yeah, thank you so much for having me. It was a great honor.
Thank you. I would like to invite all our participants, and you can show your smile in the screen. We can get the group photo. By the way, I have to announce that 2 weeks later, we have another special topic. The topic is the revision orthodontic surgery and the revisions, the facial bone contouring surgery by Professor Lee from South Korea. That would be a very wonderful topic for all of you who are interested in this issue too. Although we have still some of the question not yet be answered, so I still thank you, and please, Michael can give the answer, and later we can post in our webinar, the platform in the Facebook. Okay, thank you so much. So allow me to count to three, and allow yourself to refer your big smile to us, please. It's our group photo time every time. Hello, Narisapong. Hi, Fukui. Hello, Clarissa.
Hi, Fayun.
Hi, Anoop. Professor Lunzo Low. Hi. Okay, I will count to 3. 1. Hi, Dennis. 1, 2, cheers. Thank you so much for all of your coming. We still are very happy you can come join with the webinar every time. And if you have any question, you can keep in touch with all of us. Finally, thank you, Michael, and thank you all our participants tonight. Good morning and good evening. Okay, see you next time. Bye-bye.
Thanks, everybody.
Bye-bye.
Have a
Bye-bye.
wonderful day and night. Get
You
some
too.
sleep.
Have a good
Yeah,
day.
have a one day. Have a good day. Okay, thank you, Prior, and thank you, Junior.
Yeah, so
Okay.
how should we give the questions to Professor Hutz?
Maybe Dr. Junior, you can send to me, and then I summary everything and send to Dr.
I
Mike.
already summarized the questions, so it's already in a Word document. So if you want it right now, I can just like
Yeah, you can send into the group. No
yeah,
problem.
okay, then that'll be easier.
Yeah.
Yeah. Thank you so much.
All right.
Okay.
Yeah. See
Have
you
a good
for
one.
the next
Bye-bye.
time.
Good night.
Yeah.
Good
Have a
night.
good night.
Good night.
Good night.